Interventional therapy of atrial fibrillation, state-of-the-art 2021.
So dear professors, colleagues in Vietnam and Germany, again, it's a great pleasure for me to be part of this symposium here of the Central Vietnam. And today I want to talk about the interventional therapy. It's my daily routine here in St. Vinzenz-Hospital in Cologne, the interventional catheter ablation therapy of atrial fibrillation in 2021, state of the art. So you all know that in 2020, there's an update in guidelines of the ESC in treatment of atrial fibrillation. And you can see here that catheter ablation, atrial fibrillation, pulmonary vein isolation is a clearly class 1 indication, also in paroxysmal atrial fibrillation, persistent fibrillation, and also in persistent atrial fibrillation with major risk factors. And now, what is the cornerstone of catheter ablation of atrial fibrillation? You all know the STAR AF2 study, and this study have compared ablation of persistent atrial fibrillation and have divided the patients in 3 groups. And you can clearly see here that all the 3 groups have had the same outcome, whether you do only pulmonary vein isolation or added some electrogram ablation or line ablation. So actually, the complete electrical isolation of the pulmonary veins, the so-called PVI, is still the cornerstone, is recommended during all catheter ablation procedures. Now, in the development of the therapy of atrial fibrillation, there seems to be one subgroup of patients who will clearly get benefit from catheter ablation. These are the patients with heart failure. And I want to present the study, the so-called camera MRI study. And this study have compared catheter ablation versus molecular rate control in atrial fibrillation in patients with systolic dysfunction. And these studies have concluded that there's additional benefit of catheter ablation despite sufficient rate control in these patients. So there were included were patients with persistent atrial fibrillation with reduced ejection fraction below than 45%. And you can clearly see all these patients were good heart rate controlled. And after catheter ablation, you see an increase in left ventricular ejection fraction from more than 18% in the catheter ablation groups, comparing to 4% in the medical rate control group. The others have done the pulmonary vein isolation and also the box line, the posterior wall. And the results confirm the results from the Marouche study, the so-called Castle AF study. And this was the first study that have shown a benefit of prognosis in patients after catheter ablation. And these are all patients with markedly reduced ejection fraction and an implanted device like an ICD or CRT. And you've seen here that concerning the combined endpoint of death or hospitalization for worsening of heart failure, the catheter ablation group is superior to medical therapy group. So that was implemented in the actual guidelines from 2020. So the guidelines mentioned that AF catheter ablation is recommended to reverse LV dysfunction in AF patients with reduced ejection fraction, and should be considered in selected AF patients with have to improve survival and reduce heart failure hospitalization. So this is the indication for catheter ablation is widened. Where I want to show you one patient here in our clinical routine. This patient was coming to the hospital with tachycardia more than 100 beats per minute with the persistent atrial fibrillation and dilated atria and reduced ejection fraction of 32%. And it's important that after is sufficient rate control, the ejection fraction is still 37%, and the atria are also elevated. So under sufficient rate control, the hemodynamic situation was not improving. So we have done the catheter ablation. This patient, we've done the pulmonary vein isolation. That was the 3 months after catheter ablation. You see a fully preserved ejection fraction and a normalized size of the left atrium. So here you can see that there's some kind of reverse remodeling concerning the left atrium. To go more in detail, you see the spectral tracking of the left atrium here, and important is here that in time of atrial fibrillation and large atria, there's only 3% of booster function of the left atrium, and after catheter ablation and reaching the sinus rhythm, the booster function is increasing to 20%. So when to do the catheter ablation, and there are some data who shows us the rationale for early rhythm control strategy. As you all know, atrial fibrillation is a progressive disease. And there are some studies to show us that, for example, there's a 8.6 and 24.7% transition to persistent AF in one respective 5 years. And ULAD shows that there's a 20% after 1 year transition from paroxysmal stadium to persistent stadium, and 30% after 1 year transition to permanent atrial fibrillation. And Padfield et al. Have published 2017 that there's a 40 to 50% progression from paroxysmal to persistent atrial fibrillation per year. So in line of this publications, an early rhythm control strategy to stop or delay progression may be favorable. And so Karl-Heinz Cook have done the so-called ThS study to investigate this topic. So that was the multi-center randomized controlled study, and have included patients with paroxysmal atrial fibrillation, and they were divided in 2 groups. There were the radiofrequency ablation group and the antiarrhythmic group. And the aim of the study is to show the progression from the paroxysmal to the persistent stadium of the atrial fibrillation. And the result of the study was that there is a significantly lower rate of persistent atrial fibrillation with ablation than with antiarrhythmic drugs. So the development from paroxysmal to persistent forms of atrial fibrillation can be delayed or stopped by an early catheter ablation procedure. So in conclusion, in patients with refractory paroxysmal atrial fibrillation, early radiofrequency ablation was superior to antiarrhythmic drugs in delaying progression of persistent atrial fibrillation. In line of this, there was the so-called EAST study published last year from the Kirchhoff and group that was the early control therapy in patients with atrial fibrillation study. And this study have include a large number of patients, more than 2,800 patients, 2,800 patients, and who were divided in rhythm control strategy and in usual care. That means that the vast majority in the rate control group, and there were screen randomized treatment, and there was the long time follow-up, nearly 8 years follow-up, and the results were impressive. There was a combined endpoint of death of cardiovascular causes, stroke, ACS, hospitalization with worsening of heart failure. There was a significantly superiority of rate control strategy comparing to usual care, comparing to there was a superiority of rhythm control strategy comparing to rate control strategy in this study. But the study was there was a common group of rhythm control. That was not a specifically catheter ablation study. But here we can see that the rate control strategy may be favorable. So at the end of my talk, I want to highlight some new technology in catheter ablation, and there, to now, there are two energy forms. That is the radio frequency energy and the cryothermal energy, who were used in the vast majority of the catheter ablation procedures worldwide. But there's a new energy form upcoming that is the so-called pulse field ablation, the so-called PFA. And pulse field ablation has the potential to combine a high ablation success rate with no or minimal complication. Pulse field ablation is a form of irreversible electroporation that uses a train of bipolar and biphasic pulses. So-called, the pulses are like some small shocks, some electroshock of high voltage, more than 500 volts, and short duration to create tissue injury without significant healing. And the mechanism of lesion formation in electroporation is a function of electric field exposures that break down cell membrane. We want to reach the cell membrane damage, leading to cell death. And the unique feature of pulse ablation, tissue specificity. Myocardium is very susceptible to irreversible injury, whereas the esophagus, phrenic nerve, pulmonary vein, and coronary arteries are relatively resistant to injury. That is a very important aspect, that the pulse field ablation has some kind of tissue specificity. And this is the catheter. This from the Medtronics Corporation. This is the circular catheter with gold electrodes, and we are do some kind of repeated pulses here, and all the cycle of the pulses is only 36 milliseconds. And so after 2 or 3 cycles, one cycle is only 36 milliseconds, was possible to eliminate here all the PV potentials after this ablation with pulse field ablation. So that was very impressive data, that you can reach a pulmonary vein isolation after a few seconds of pulse field ablation. That was a histological section of a porcine atrium 2 weeks after pulse field ablation. You see here the sharp scar here after ablation, and the epicardial fat and the arteries here, there were no damage. There was absolutely intact, and so that shows that the pulse field ablation is tissue has some kind of tissue specificity. Now, Vivek Reddy have done some work and some follow-up after patients undergoing pulse field ablation, and has shows a very good safety profile with only one complication in more than 80%, and they have no severe complications like esophageal lesions or phrenic nerve damage or pulmonary vein stenosis. Remapping these patients with 3D systems shows a very sharp here isolation line of the pulmonary veins, and important that the lesions at the clinical outcome is very high. The lesions may be very durable. So Vivek Reddy could show us more than 85% of success rate after 1 year. So this, in my opinion, this is a promising new feature in pulmonary vein isolation. So, ladies and gentlemen, let me summarize. Regarding new ESC guidelines in 2020, there's an upgraded recommendation for catheter ablation. So defining structural and functional left atrial values is crucial for individualized subset-based ablation strategies. So early rhythm control strategy may be favorable. And there's an improved outcome after catheter ablation in patients with heart failure. And concerning new technologies, the pulse field ablation PFA is a new energy form and have promising data for pulmonary vein isolation. Thank you for your attention.
Thank you very much, Dr. Quang, for your presentation. And there is a perspective for early ablation as compared to anti-arrhythmic drugs in prevention of the heart failure. But what do you say about early? How early? Is there a scoring system to?
Yeah. Actually, thank you for this good question. But actually, there's no scoring system because early, so we should think about that. Early means as early as possible, because okay, from the first diagnosis, it's too early. But when a patient is coming and he has a symptomatic atrial fibrillation and have 2 or 3 recurrences of atrial fibrillation, so you can sit with the patients and discuss about the therapeutic options. And when you know that early ablation can stop or can delay the progression from paroxysmal to persistent in young patients, maybe the patient is 40 years or 40, 50 or 60 years. So you can discuss with him to ablate the atrial fibrillation after 2 or 3 recurrences of atrial fibrillation.
So we have to discuss with the patients about effectiveness and the cost and risk. So what is the risk of the ablation?
So
you open the indication.
There's a nice study from my friend Chuyên. He has shown that the pulmonary vein isolation with the cryoballoon after 3 years is very cost effective. This is more cost effective than medical treatment of atrial fibrillation. That was the first question. Also, the pulmonary vein ablation with a cryoballoon is very cost effective. And of course, you have to discuss the complication rate of the patient. There are severe complications like a stroke, like esophageal injury, like tamponade. But with the new device, see, for example, the cryoballoon device, and with the new 3D systems with high density mapping and also new catheter design with force measurement during the ablation, the severe complication is actually very, very low. It's below than 1% in normal cases with atrial fibrillation. And so in this, so that I can summary that also in young patients we can perform the atrial fibrillation with a very low complication rate.
Thank you, Dr. Quang.
Okay. Yeah.
One question. It's
yeah. Good afternoon, Professor from Germany.
Yeah.
So I would like to ask you one question to Professor Đinh Quang Nguyễn. So I am very interesting about your presentation. A lot of the technologies from the ablation of atrial fibrillation. And so in your presentation, you mentioned the new techniques for pulse field ablation. So what is the disadvantage of pulse field ablation?
The disadvantage, yeah.
Yes.
Okay. I show you. In my opinion, there's very much advantages. There are less disadvantages of this new. One of the possible disadvantage is that you have always have that in some case you have only a circular ablation with one energy level. So you know that in the pulmonary vein, for example, in the left pulmonary veins, you have anterior at the ridge side, you have very thick tissue, and in the posterior wall, you have very thin tissue. And with one shot of the circular catheter, you have only one energy level only for anterior and posterior wall, and so that is maybe a possible disadvantage of this technique.